Well, good morning, everyone. Thank you all for being back for day two. It's great to see you all here this morning. I'm going to invite our forum co-chair, Malcolm Cox, to have the perhaps unenviable role of trying to help us to bring together everything that went on yesterday. We heard from individuals across multiple disciplines and a whole variety of different topics, and we've asked Malcolm to simply reflect on what he heard yesterday and what that may mean for the future in his eyes. So, Malcolm, thank you.
Thank you, Chris. Let me add my warm thanks to Andrew and Jeff and all of the simulation folks last night. I did go up there and I felt very old. I first remember getting into some of this with an address I heard. It must be 20, 25 years ago, and I can't remember his name, but he was one of the directors of the Walt Disney Imagineering division. I don't know if it's still called that, but it was magic then. It's even more magic now. And when I tried to do a little surgery with the Da Vinci, I discovered I was totally incompetent. So, but thank you for that, because I think it was an interesting and very different sort of set of frames that we had to deal with compared to what we were talking about during the day. So welcome back. This is an example of resilience. You're here on the last half day of a conference, which is the dead zone. So we hope, we know that there's a lot of important information for you still to absorb and deal with today. But thank you for staying. Susan sends her apologies. She had to go to an important meeting. But she did leave us with an important concept, which is not a unique concept, but I thought was nicely said. We are preparing learners for a health system that no longer exists. And I think you all have your own particular way of saying that. But it's really true, and it's a tragedy. Because not only are we preparing people incorrectly, we're spending huge amounts of money on it in a wasteful sort of fashion. So I thought that was one of the most important lessons that we learned generically from all the speakers yesterday, because the glue that held together what people were talking about yesterday was we've got to change the way we're preparing learners so that we have a very different workforce than we have currently. Just to remind you, and I think this is important, who we heard from. We heard from Chris Olson and Beth Mancini, who I need to thank for being the conference co-chairs for this. They still have a little bit of work to do, but we'll thank them now. And I thought Chris had another interesting sort of metaphor. And that was the evolutionary metaphor. But if you recall what he said, he was talking about what he termed punctuated evolution. That is, how do you roll a square ball? How do you get to the tipping point so that it falls over? And I'm not sure we're at the tipping point yet. If we knew how to get to the tipping point, I think we'd be a lot better off. And I would think that this forum needs to think in terms of a conference or a session or a workshop around how do we really tip that square ball, not ball, but that rectangle over. Because I don't think we're there yet. But I thought the concept of blocks and balls and punctuated evolution was an important one. Just to remind you who else spoke, Francisco Campos from Brazil talked to us about the similarities and differences between our healthcare system here and in other parts of the world and the one in Brazil. And I thought that kicked things off very nicely. Susan Skochalak had a panel that included Art Kaufman, David Asprey, Elizabeth Baxley, Terry Walpole. And all of them spoke from a perspective of curriculum design and structure. And I use that term broadly, curriculum design. I don't mean classroom curriculum design. I mean the broad concept of curriculum design, which I think is an appropriate one. Timmy Barwick went on to talk with some small table discussions around educational roles now and in the future, which flowed directly from these curriculum innovations that we had previously heard about. Deb Troutman managed the debates on work-life balance, something that we don't model very well. And that's probably the biggest problem with work-life balance, is that we are not very good models for our trainees or students. But I think it's an important topic. And Rick Talbot, Rick Valachovic, who will forever be known as the two Ricks, provided some of that interlocution, and we had perspectives from both Nigeria and China on that. Holly Wise did the second debate, which was an interesting debate on task-specific workforce roles that Liza Goldblatt, Elaine Tagliarini, and some perspectives from Nigeria again. And we ended up with some accelerated table discussions and brief presentations on health literacy from Andrew Pleasant and Cliff Coleman and Jennifer Cabe, which I thought ended up the day in a little bit of a rush. There's never quite enough time at the end of the day, but they valiantly persisted, and I think it was an important discussion. So what were some of the lessons that I took away, and you can decide whether these are the right lessons, but I would ask you to reflect on what the lessons are, because if you don't reflect on what you're doing, you're not learning very much. So these were my take-home messages. First and most important, and I bolded this in my brief notes that I made here, no Xeroxing. Thank you, Professor Campos. I think that's a very powerful metaphor, because what we tend to do is clone and recreate the same stuff. And we can't go on doing that. So I think this idea of thinking creatively beyond just doing more of the same, no more tinkering, much more radical, although a change, I think, is important. We heard a lot in a lot of different ways about the social determinants of health and the broad concepts of health as opposed to health care. We heard important information of the transformative roles of communities and community health workers. And we've had already a workshop on community health. But I think we need to have more incisive, deeper dives into this issue. And I'll come back to that in just a moment. We talked about the importance of redistribution financing, or insurer-related financing in a capitated system. This is what Art Kaufman talked about, and there was some discussion about that. The fact of the matter is there's no more money. So you can't just get stuff to add to the pie. The pie is stuck in the size it is. And so the debate has to be about redistribution. If you want money for X, what do you take money away from? And that's a tough discussion. But I think it's a really critical discussion. We talked about the pillars of the curriculum, and the concept being increasing the size of the pillar that was devoted to social determinants of health, or health literacy, or whatever construct you want to think about. And I think Terry Walpole showed a slide in which, in her view, in the curriculum at Penn State, they had achieved some balance between the biomedical part of the curriculum and the social determinants of health part of the curriculum. But that's insufficient. If 95% of the woes in the world come from social determinants of health, disparities and so on, then shouldn't that pillar be 95% of our curriculum? Gee, we haven't even solved the outpatient care piece. We still have a focus on the inpatient care. And yet I think there needs to be a bigger focus on social determinants of health. Now, we are having a consensus study devoted to, that Susan's going to lead, devoted to social determinants of health. But if they're really that important, don't ask for equality. Ask for it all and get most of it, is the advice I would give you. Because if you just ask for little increments, all you're going to get is little increments. You're going to get tinkering with the curriculum and not radical change. I heard a lot of comments about the importance of language. I loved one that people formerly known as patients. I mean, that's a very powerful statement when you think about it. So I wondered whether communities were formerly known as populations, but I don't want to upset our population health mavens. But I think that there's some legitimacy to that. Art Kaufman in Radical Table number 7. I don't know if it's as radical today as it was yesterday. Maybe it is. Well, art isn't the only radical revolutionary at that table. But he talked about, came back to the concepts of communities and said if you really want to change and involve communities, get them to be the majority on academic health center boards. I mean, it's an easy task for you. So I had to think, well, how would you do that? What stick would you wield to get the community more involved in academic health centers? I mean, every academic health center has a token community representative or a token patient, now called people representative, right? But how would you expand that? And it occurred to me that the way to do it was how we got Al Capone. Go after the academic health center's tax-exempt status. If they're given 501c3 tax-exempt status because they're public goods, they better darn well be public goods. And I don't know any way of getting them to be public goods other than threatening their tax status. You may have some other ideas. Now, that's a political nightmare, obviously, but it's concepts like that, not that necessarily, but concepts like that that I would submit that we need to think about. Because otherwise we're going to talk and get to know each other and tinker at the edges, but we're not going to have any impact. So I thought that the community sort of discussion was an important one. We come back to importance of language with task shifting versus competency sharing. Words are powerful. And so Afaf Malise reminded us in the brief time she was here yesterday that maybe task shifting isn't the right word, but competency sharing might be. I also worry, as I worried about language last night, tripping up, and I've tripped up and we all trip up over this classification of different healthcare workers as either professionals or non-professionals. Now, I know that there are formal definitions of professionals, but we better be very careful in the way we speak about, I'm going to put it, because I don't know better words, the lower end of the scale. And I don't mean that in a pejorative sense, but the people who form the base of the pyramid for health anywhere in the world, and that is the community and community health workers. And to think of them as non-professionals, as some people do, is, I think, the wrong way to go about this. So I think, again, this language issue, we need to be careful we don't get tripped up on. And then I ended up the day, I think, confusing everyone by trying to raise the question of how do we bring all this together in a productive, action-oriented package? And I chose the poor health literacy speakers because they were, at the end of the day, to say, you know, how many more of these ideas of curriculum inclusions or invasions could we deal with? Isn't there some bigger construct? And so I wanted to show one slide with apologies to Art. And someone asked for Malcolm's calendar. Well, it isn't my calendar. It was Art and the health literacy. They have slides the same way. What are all the components of health literacy? But this was the components, the sort of things that were... Oh, hell. You know, we got to get a lavalier, because I wander around a lot. Yeah, I see it. But if you don't put it on me, then I don't use it. I need all the help I can get, I can tell you. But I was thinking that we need some broad construct, and Art's broad construct for how you get all these elements in the curriculum. You know, you don't need a transportation course, a food course, a housing course, a utilities course in your health professionals course. You can't do that. The way The community-oriented people do it is by putting people out in the community. The way the health literacy people do it is by bundling these or related concepts into the broader construct of health literacy. I can talk to leaders of academic medicine about community-based learning. I can talk to them about health literacy as a bundle of these concepts. I can't talk to them about each and every one of these. So that was the construct that I was trying to get across, a sort of all-encompassing, how do you go about making change? You've got to build a model that actually makes some sense and then follow it. So this is apologies to Art. As I say, I could have done the same thing with Andrew and Jennifer's health literacy thing. But I think it's really important that we think conceptually about how we're going to deliver the elevator message, 10 seconds, to the people who have all the power and all the money in the system at the moment. And to get them co-opted, we need broad strategies. My own view, which is I was trying to get across yesterday, my personal view is that if you get them out into the community, everything else follows. If you get them out of the ivory tower, it's going to work. So that community sort of focus, I think, is critical. I've probably gone on too long, so I'm going to stop there, but just want to end by thanking all the people, not only who stayed for today, but the people who worked hard to bring us the information yesterday. So thank you, Beth, and thank you, Chris. I turn it back to you.